I'm Michael George of Sagesse Healthcare Consulting, and this is the Pioneering Patient Podcast. Now, this podcast won't offer you any medical advice. We'd advise you to go to the doctor for that. But we're offering you informative, thought-provoking and inspiring patient stories. Today, my guest is the CEO of a patient group whose mission is to avoid misdiagnosis and to open up access for patients. But she then found herself suffering misdiagnosis and not having the access to the treatment she needed. So, Selena, I welcome you. Celina Gorre, of the Chief Executive of the WomenHeart. I welcome you to the Patient Podcast.
Thank you.
So let's start by asking you a little bit more about WomenHeart.
Sure, yeah.
What are you dedicated to? What are you intending to resolve? A major issue, I think, in women's health in the US.
Well, thanks for having me, Michael. This is a real honor. So WomenHeart has been at the forefront of the issues surrounding women with heart disease. It's been fighting this fight for 25 years. It's our 25th anniversary this year. And really, it was created because women were having really downright unsatisfactory experiences of trying their best to get a heart disease diagnosis, failing to get one, and then having some real significant repercussions and at the end, sort of poor outcomes.
It's a big question. Why do you think women are having these poor outcomes?
I mean, I think it's systemic. I think it's not just, I don't want to lump it all onto the healthcare system. It's the sort of society as a whole. You know, women are not just the mothers of families, but we also are the caregivers of the world. We know that, for example, 70% of people who work in the healthcare industry globally, 70% are women. And the issue there is that women often will put everyone else before them. And what I want to make sure doesn't happen is that sounding like I am putting all the onus on the women. I think this issue is systemic, it's societal, and this manifestation within the context of the diagnosis, misdiagnosis, delayed diagnosis of women with heart disease is just one kind of symptom of this wider, inequity in sort of gender dynamics. Yeah.
So you're trying to resolve this big issue, and you have to organize yourself across the whole of the US. How have you organized WomenHeart so you can support women across the whole country?
So we've been really lucky to have a model that has been successful for the last 23 years of us training women with heart disease in collaboration with the Mayo Clinic to become expert patients is what I call them. They go back into their communities. They provide peer support, running support groups in their communities, but also coming to Washington, D.C. and advocating with their representatives on Capitol Hill to improve access, to improve quality of life, but also to raise awareness that heart disease is still indeed the #1 killer of women as well as men.
So for women, I think they're called champions, aren't they?
That's right.
So there must be Women Heart champions. So they need to get something out of this to be volunteers for this. So what is it giving to them as well?
Do you know, the biggest, most consistent message we hear from Women Heart champions is that they don't want anyone else to go through what they've been through. So the biggest thing they're getting back is a satisfaction of knowing that the horrible kind of experience that they went through will be hopefully something of the past, and that they can help other women be diagnosed much more efficiently.
So going back to when you first joined WomenHeart, you had 15 years experience in the area of patient advocacy for women. So tell me more about that background and how that helped you to then join WomenHeart.
Yeah, so actually my background was in global health broadly. I started off in the HIV/AIDS space. I spent some time in New York City with something called the Global Coalition on HIV, malaria, and TB. And then I spent 2 years in Angola with the United Nations. And then went back to New York, worked for the UN, running something called the Foundation for the UN Global Compact, which is really more sort of a corporate responsibility initiative. And then finally, before coming to WomenHeart, I lived in London for 8 years, and I was running something called the Global Alliance for Chronic Diseases, which is what really piqued my interest in thinking about the biggest killers of the world, and obviously heart disease is right up at the top of that. So my interest has really been in thinking about solutions at the macro level and thinking and studying all the different important stakeholders and actors and duty holders in this kind of global fight to improve health more generally, and which is why I sort of landed at the doorstep of WomenHeart, not just because heart disease is our #1 killer, but because there's at its core, WomenHeart is fighting an injustice that women are not getting the care that they deserve and the diagnosis that they deserve when you compare them to the experience of men.
Yeah. So you, at the time you were well settled in London, you weren't thinking of going back to the US, but what made you think, okay, I'm going to do this, I'm going to go back to the US, it's too important a job, I need to do it?
I mean, you know, Michael, I mean, I thought I was just going through the ropes of practicing, kind of as one does, sort of going through an interview process. And the more I spoke to the board of the organization doing the recruitment, the more I realized that as the country was sort of in this, let's say, political turmoil, what we really needed in the country was as many spaces of civic engagement as possible, so that people would come together of different political persuasions to talk about something really important and meaningful to them. And Women in Heart Disease is exactly that. It's a perfect example of something that brings people together from different walks of life, from different belief systems in some senses. But we can align on this. And I thought that this was a really wonderful opportunity for me to give back to the US, which has been a really important part of my journey and my family's journey. And I decided that this was the right next move for me, and I have not regretted it.
So you haven't regretted it, and you're back in the US, you're helping women who have issues with heart disease. Then in 2021, you start to think, there might be something here happening to me. But tell us more about that.
So I remember the first time something was happening, I was sitting, 2021 was smack dab in the middle of the COVID pandemic. I was sitting on a Zoom call, and all of a sudden I could feel my blood pressure spike, kind of out of nowhere, out of the blue. And that happened a few more times. So I went in for my first round of visits to the emergency department, each time being sent home with a non-diagnosis, sort of, nothing's wrong, we can't find anything wrong. And I proceeded for the next 2 years to have a variety of tests to be put on antihypertensive medication. And this just kept happening and happening. So over 2 years, over 9 visits to the emergency department, I finally got an angel sent to me in the form of a young doctor in the ER who said to me, look, I'm going to tell you the exact same thing I told you, you were told all those other times. What would you like me to write in your discharge papers? And all of a sudden, he was kind of speaking to me as an equal. And I knew exactly, I didn't realize that I knew exactly what I would say in that moment, and I knew exactly the doctor I wanted to see, so he put that in my discharge papers, and within 2 weeks, I was in a cath lab getting the exact right test I should have been getting, and got my diagnosis within 30 seconds on my birthday. So that was sort of a birthday gift I gave myself.
Looking back, you got your diagnosis, but let's look back to the 9 times you went over 2 years. And someone in your position, to say, well, if it's happened to you, it can happen to anyone. So how did this happen?
So I think a couple of things. No matter how much knowledge one has, when you're in the ER, you're a patient. And the relationship you have with that ER doc is a relationship that any person walking into the ER will have, including having self-doubt, including, I sort of said to myself, maybe it is anxiety because all these other times before I get no diagnosis. So I think that what's really important is to let yourself be a patient. Mm-hmm. I had all of these sort of competing thoughts in my mind, including, Selena, speak up, or, this should go differently for you because of who you are and what you do and all of that. And it was an incredibly powerful way to understand my work and to understand the women who share their stories every day, who are brave and, so determined to make a difference for other women. So my orientation to my work changed dramatically because I went through that process myself. But to be honest, Michael, the thing that was really interesting was that I did not want to share that diagnostic journey, just in case it wasn't my heart, even though deep down I knew it was. So kind of multiplying that for other women who, may not even be in the health field, who will take that non-diagnosis as, a sense of relief, actually, that, there is nothing wrong with their heart, and that could be really detrimental to ultimately getting the diagnosis they need and deserve.
So when you were leaving the hospital, what diagnosis were you being given?
No, nothing. I mean, just saying, well, maybe you're having a panic attack, or maybe you just had a really stressful day and that's what was happening. I had one doctor say to me, now it's not that I don't believe you. And I thought, well, why would I think you don't believe me? And so, the conversations in the ER are really colored by what they're looking for, and what they're looking for is obstruction. So if you have any form of cardiovascular disease that is non-obstructive, you're going to be sent out of the ER thinking that you don't have anything wrong with your cardiovascular system.
And this is the problem, wasn't it? Because the condition you had, which is coronary microvascular dysfunction, CMD, is not non-obstructive. That was the issue, wasn't it?
That's right, yeah. As far as they were concerned, my cardiovascular system was clean. I mean, there's no plaque. There's nothing that they were looking for, right? Sort of the traditional blockage, which is the number one thing they're looking for in the emergency department.
And so the diagnosis came partly because there was a new form of diagnostic, is that right? Or just you met the right person?
I met the right person. And in the U.S., at the time, there weren't that many centers able to go through this diagnostic process. But like I said before, I knew the doctor to talk to who would believe me in order to then make the appropriate referral. And I walked into her office and I said, I need to be checked for microvascular disease. And she said, you're absolutely right. And I know just the person, and booked the appointment.
So the fact that it's difficult, CMD is difficult to diagnose, doesn't mean it's impossible to diagnose, right, as you found out. So why do you think they weren't able to do that for so long? Why was it missed for so long? What are the issues in the emergency room?
Well, I also want to reframe this. It is not difficult to diagnose. It is that currently the system is not, going the full length of the cardiovascular diagnostic journey. Right. So as I think about this, I should have been referred to be checked for non-obstructive cardiovascular disease. But instead, the road that they took was anxiety or panic or stress, which sounds reasonable to somebody who has chest pain. The chest pain has subsided after 4 hours of being in the ER. And so you think, oh, well, that sounds reasonable. But the recurrence, in a way, thank goodness that I kept having the recurrence, because it kept me determined to find a diagnosis.
And the point you're making in WomenHeart is too many women are being told the wrong thing. They've been told it's
That's right. I mean, I can lament about 2 years of this journey for myself, but I've heard 7 years. In one case, a woman had 43 years of going back to the system and being told that nothing was wrong. On the 43rd year, getting a diagnosis. So, you know, in that context, I count myself pretty lucky.
Now, based on your experiences, what are you doing now to change the way things are done in the emergency setting?
There's a couple of things. One is just to be as loud as I can be about my own story. You know, stories are powerful. I don't lead with it. You know, I lead with our work and then sort of at the end sort of talk about my own experience. But secondly, I'm really pushing for us to think about the solutions from a systems perspective. I really get frustrated and frankly a bit tired when I hear all of the onus put on the individual to fix the system. We're not going to get anywhere if that's where the focus is. I appreciate that we should have greater awareness and education and access to information, but this is a systems problem, and so we need to think about system solutions, and that's a big part of my advocacy. For example, in talking to the emergency physicians and what can be done differently in the ER setting. We talk to other sort of physician associations, professional associations, about how to think differently. But lastly, we are trying to develop programs at WomenHeart to make sure that the fundamentals are being addressed. So I love quoting Dr. Martha Galati, who talks about the fact that if guidelines were implemented perfectly, we would get rid of 80% of delays and misdiagnoses. So we're saying we already have these processes. They're just not being followed, and there's some sort of uneven implementation across our healthcare system. And that's a lot of the pieces of advocacy that I do. But I'll say that the one huge tip I give to women is if they show up to the ED and they show up with chest pain and they are sent home with no diagnostic exams, I say to them, you want to then tell them, okay, please put it in my record that I asked to be checked for a heart attack and you denied me those exams. And that changes the power dynamic. This is also about power, right? It changes the power dynamic and puts it partly in the hands of the patient.
So it's women taking power, taking control. That's
absolutely.
Very important. So you've now been leading WomenHeart for 5 years, five and a half years. If you look ahead 5 years, what's your vision? What's the mission? What do you want to change in the next 5 years?
I want us to lead the charge to making sure women know that heart disease is our #1 killer, number one. I want us to really rethink this idea that lifestyle interventions are not possible, because they absolutely are, and we need to be talking about that more. I want us to reframe prevention as everyday heart health. Prevention sounds really daunting, and for somebody with heart disease, it feels like they're not talking to you. But the things that you can do every day are the same, whether you've had a heart attack or you have zero risk factors in terms of improving your heart health. So I want us to kind of get rid of these silos that are useless, really, when we think about the framing of this work. And we want us to talk more about what we have in common. And in our case, women without heart disease and women with heart disease have a lot more in common in terms of how they can improve their health going forward.
And you've also talked about, I think at times, about changing the language that's used, changing the imagery that's used, the way women and men are portrayed, perhaps.
Absolutely, yeah. So, that's right. I mean, I think Hollywood and those sort of corners of our society that put out images, whether it's in movies or social media, can play a huge part in helping us rethink what a typical heart attack is. And when you watch movies, it's sort of this middle-aged white man clutching his chest and sort of keeling over. when we know that for women, heart disease doesn't always look like that. And so these biases are pervasive, not just in the general population, but also within the healthcare setting, which is really where the challenges lie.
So Selena, I wish you all the power that you have to change the power dynamic and help women to take control of their heart health. Thank you for joining us for this podcast. So thank you very much.
Thank you very much.
Thank you. So that brings us to the end of this edition of the Pioneering Patient Podcast. If you've got ideas or guests to propose for the future, please contact me on the email that we'll give at the end of the show. So that brings us to the end of this podcast. Thank you for joining, and remember, take good care of your health.